All right, welcome everybody. It's Dr. Bustai. It's a pleasure to be with you in this session. We're going to be doing a case-based integrated review. We're going to be specifically doing 2 cases today. And as we do these, there'll be a number of topics ranging from pediatrics to geriatrics to chronic care to acute care and stuff in between that kind of cross over back and forth. And that's meant to provide a kind of a broad-based experience. And some of you may be saying to yourself, but I don't care about what happens in the hospital. I don't care what happens in an ICU. I'm going to work in the ambulatory care clinics or primary care or the community-based practice. I'm not going to be taking care of people coming into the emergency department. I recognize that's true for some of you, and vice versa. Some of you are going to be in the hospital and you don't care what's happening in the, I'm not saying you don't care, but it's not your major focus. The point of the matter is, though, a good, well-rounded, competent clinician is able to understand and navigate patient care scenarios and things that happen to the patients that we serve on both spectrums when we know what happens in both areas. So I practice in emergency medicine. That means that patients come in the emergency department, obviously, and that's different than a primary care visit. At the same time, I do, interestingly, quite a bit of primary care. People come in for refills. People come in for high blood pressure issues and their diabetes out of control or whatever, and I have to navigate them back to their primary care. I need to understand what the primary care, ambulatory care, community-based practice folks are doing and their purpose and how it works, and vice versa. When I would, when I was a pharmacist and practice in like community-based environments where I was doing dispense medications from the retail pharmacy, I was intervening on hospital cases, the patients getting discharged, because I understood what happened to them in the hospital. And so please don't go through your training with a narrow mind and a narrow perspective. You're going to be a better clinician when you're well-rounded and you have a perspective about patient management and care across the spectrum. Okay, and that includes pediatrics to geriatrics and such. And I know some of you may eventually migrate or navigate into specific areas of pediatrics, adult, geriatrics. I get that. But you still have value of knowing some basic things of what happened to people as they age, and also on where they come from. So if I discharge a patient from the hospital and they come back to the primary care clinician, to the clinic setting or the community-based practice, then that clinician should kind of be familiar with what happens. And I just want to shed a little bit of that light as to that perspective on how these are set up and why I think that no matter what your interest is, all of these are very important, not only for like board exams and your training, but become very important in real world clinical practice. Because what my experience says is when clinicians look at the world only in their little limited perspective with blinders on, they actually miss the opportunity to intervene and be a contributor to that patient's care. And so please keep that in mind. All right, for those of you that may or may not know me or we've not interacted before, my background is unique. I trained as a nurse initially with minored in biology. That's where I fell in love with pharmacology. Went on and got my PharmD while I worked as a nurse in the surgical trauma ICU and in the emergency department. Then did a residency and then taught pharmacy school as well as nursing school in the nurse practitioner programs. I taught advanced pharmacology in the pharmacy school. I taught adult inpatient internal medicine and ambulatory care practice. I had about practice in both environments, which is why I give the bias and the perspective that I give, because I thought it was very valuable that I had a clinic, but I also practice on the inpatient side. I did clinical research for about 7 years and then went back to medical school because I really had a desire to understand the diagnostic process and the workup. And then I also wanted to take a little bit more control over the patient care because of the things I've been seeing. But really, my passion was medical education of the entire healthcare team. And having trained in all those environments, I bring a unique perspective, and I hope that you find that to be valuable. I recognize that certain aspects are not as relevant to you or to your exams, but the point is that we all take care of the same patient. There's not a diagnosis and a workup for a pharmacist who sees COPD versus a physician who sees COPD. It is COPD. We both contribute to the management and the care of that patient. Nurses, pharmacists, physicians, everybody involved in direct patient care, see the same diagnoses, follow the same general guidelines, standards of practice. So there's not practice standards for each individual. There's obviously different perspectives, but the whole healthcare team is important. And so I felt like by doing my training in medicine, I was able to sort of complete that loop and then help each other cross over and understand that. And so that's just the unique perspective that I bring, and I hope that you find it to be valuable. My training was in emergency medicine, and then I actually went on and did sort of graduate/fellowship training in evidence-based medicine, specifically evidence-based healthcare at Oxford in the UK. And so I'm a little bit of an EBM junkie. I bring in evidence into why we do what we do because it's the basis for why you do what you do. Okay, I mean, I can tell you something, or a faculty member can tell you something, and you might go, okay, well, that person should know and they must be right. But you really should know where that information came from, because what I've learned through the years is people taught me things that was actually not correct, or was taught to me in an improper context of its application, i.e. overgeneralized data beyond its intended purpose or what the question was from the original research. And so I have a strong interest in teaching to you and building into your knowledge base as you go to a higher level of competency, the proper context of why you do what you do and why it applies to this scenario. It may not be applicable to another scenario. So that's a little bit about me and my background and the bias that I bring into some of these cases. But it also, I think, is the reason why, you know, a lot of institutions across the country and stuff utilize our products for this purpose, is because it is a different perspective that looks at the big picture but integrates knowledge, brings that, you know, tacit, explicit knowledge to a higher level understanding of competency called tacit knowledge, and then getting to true understanding and competency, which is where most clinicians need to be. And the real question, or the real test, is not the board exam for your licensure. The exam, the real test, is the patient sitting in front of you. That's the real world. But we all know that those patients don't present to clinic or to the ICU or to the inpatient wards as a multiple choice question, do they? So you need to understand core concepts and know how to apply them, especially nowadays on these exams where people are wanting to make sure that we are more competent. So what are you expecting from this particular session today? Well, we have two cases. Again, thinking about the big spectrum, we can't cover every topic and every disease state and diagnosis and such, so we're gonna pick two cases. And we'll go through those, and there'll be polls and questions where I'll ask you to interact, and it tracks your involvement. You won't see each other's names and what you chose and those things. So this is a safe environment, okay? So participate, contribute. This is for you. Think. Don't sit here and write down every single word coming out of my mouth, okay? You will receive the notes and the slide content into a book that will be integrated into your e-reader either tomorrow or the next day, all right? So you'll have access to all this information. So just relax, sit back. If you want to jot down a few notes, little pearls or things that you hear, fine. But the goal is for you to think and engage, like we were on rounds or we were in clinic and we had a patient scenario that we were discussing. That's what this is about. And it's also an opportunity for you to ask questions. So if you ask questions, I have another monitor here that I'm going to be periodically looking at that allows me to see your comments, questions, issues, whatever, contributions, funny comments. I don't mind jokes every now and then, right? Just be kind. But no one's going to see those, okay? So you can't see each other's comments, and that's in part to make things anonymous. Some people don't want to know what other people are saying or hear those distractions, but I will read to you what is being said. I will identify the person's first name, which doesn't determine who they really are, right? But at least you'll know that I'm reading your question if I can. Now, if there's too many questions, I may not be able to get to all of them, but that's the plan. We will take a small little 5 or 10 minute, I call potty break. If you have kids, that's what we call it, potty. We'll do that between case 1 and 2. This is about an hour and a half, so we'll have like a 45-minute break session there, okay? So I think I've kind of covered the basics. There is a handout attached to your little screen that you should see that you can download. It's got the skeleton of the cases that we're going to be discussing today. It gives you the opportunity to jot down some notes. But like I said, you will get all this information integrated into your ebooks, rereader apps on your phone in the next 24 to 48 hours. Okay, so we also need to think about the fact that we need to keep learning fun, right? I mean, who wants somebody just to read slides to you? I mean, that's an insult to your intelligence, okay? All of you have achieved a certain level of education and training at this point. You know, I'm not here to insult you. You can read stuff yourself. My job is to make it come alive, connect dots, and engage and get you to think. But we also need to have a little bit of fun. So there are some things thrown in there on purpose just to kind of make it a little bit more relaxing. Again, this is a safe environment. There are no dumb questions. There's no dumb comments. Well, maybe there are, but you are a safe environment. I am not going to call anybody out. I'm not going to pimp anybody on this session, okay? So I hope that we can just enjoy it. You can learn a lot, and then you can walk away feeling like that was a good use of your time. Having said that, let's start case one. We have a 27-year-old Spanish-speaking Hispanic female. No past medical history, comes in 1 to 2 days of malaise, basically feeling tired, progressively worsening headache, neck pain, fever, episode nausea, vomiting, last menstrual period, because she's a female of childbearing age, and knowing the pregnancy status or considering pregnancy status is always relevant to a case, all right? And you always want to make sure that that's considered in your recommendations, your evaluation and workup, and then obviously final decisions or recommendations that you make as it relates to the things that you do, not only on exams, but in real world practice. She doesn't take any meds, but she reports being allergic to penicillin, doesn't explain the reaction. She's unsure about her immunization status. Red flag, red flag. So cases and board exams, or when you do exercise or lifelong learning things, they're trying to give you hints. They're trying to give you a pattern of association. They're trying to guide you to not only the diagnosis and the problem, right, but then also issues that may come about, because you might want to use the drug of choice in a particular patient, but that may not be appropriate for that patient. So all recommendations and everything that we do should be specific to the patient, oriented to our patient, considering the patient-specific factors in an evidence-based manner. All right, so she's unsure, not good. You look at her vital signs, you see that she's febrile, blood pressure is at least okay at this point, pulse is 94, respiration's 18, she's not hypoxic, she's got 97% pulse ox on room air, so she's oxygenating. She does look a little uncomfortable, has a nuchal rigidity. Basically, her neck is stiff. So it's the diagnosis or the problem. I mean, it's not rocket science here. You don't have to have a PhD in diagnosis to figure out probably what the majority, likely her problem is. She had a CT scan of the brain because, I mean, what if it is a brain mass? I mean, I don't know, right? It's negative. She's not pregnant. So that's important, because certain drugs and treatments that we do may expose the patient, and not just patient being the 27-year-old female, but the patient inside of her. We have white blood cells of 14.5. That seems elevated. Okay, you might not have memorized your labs, but it's probably wise to be generally familiar with general averages of what is normal, recognizing that institutions do vary. Okay. But the point is, you should have an idea that, it's typically anything above 12 is generally considered abnormal in most situations. Now, it is a little different in pregnancy. It is a little different in pediatric patients, and they sometimes will put footnotes to that in the lab. But that in this patient population and age and situation, 14 is considered abnormal. Platelets are okay. Bilirubin looks good. So that's liver function. Her Glasgow Coma Scale, which is really a kind of a mental state, ability to follow commands, is pretty good. Her serum creatinine is 1.2, okay? Her SIRS equals 3. And we're going to come back to what SIRS is. And her SOFA score is 3 to 4. So you're like, what is that? And why do I care about SOFA score? Okay, well, we'll come back to it. Okay, all right. Let's do our first poll. Sorry, it's we're off one. I had one that I was going to do at the beginning, was just sort of like a general one. I kind of decided to pull it out at the end, so that's why we're on poll 2. So you didn't miss any polls. All right, let's see here. All right, so what do you think the primary problem is? Okay, again, I recognize that you don't have all the valuable information back at this point, but what is your gut feeling about this patient that they're suffering from as the main problem? And if you only had one choice, okay, one choice, what would it be? Okay, I see that at least one individual, maybe two people, have a flat affect at the moment. Flat affect is the Napoleon Dynamite look. You know, where the lip hangs down and maybe drool comes out a little bit. You're just staring off. Maybe you're even having an absent seizure. I don't know. Oh, we have a few more people with flat affects. Oh goodness. Again, we got to keep it fun, right, guys? Keep it fun. All right, we're at 1 minute. All right, that 92% of you participated. Thank you for the participation. Okay, so it looks like 73% of you said it was meningitis. 18% of you said it was sepsis. Okay, and I think that's important to recognize that 18% of you are not entirely wrong in putting that. If you look at the pattern of association, the presentation, the information, and you're weighing them on a scale of back and forth, then it probably resides more on the side of meningitis as the stronger problem, right? But you're right, sepsis needs to be considered in here, and I asked that question on purpose. Okay, now we have another poll. Let's do that, okay? So thinking about vaccinations, immunizations, which vaccine listed here, okay, now there's obviously more, but listed in this question would reduce the incidence of bacterial meningitis, knowing there's fungal meningitis, there's viral meningitis, there's even aseptic meningitis, and there's whatever you want it to be meningitis. Okay, so which one of these again would be most likely the best answer? Okay, knowing that there might be multiple answers, but the best answer is specific to this question, and the specificity of the question is bacterial meningitis. Bacterial meningitis. All right, we're at 47 seconds, so almost 80% of you. Come on, you slackers. Now, if some of you are shopping on Amazon or doing any of those kind of things, then you need to buy me a gift. Give you a little bonus point if you do. Just send it to the business address. I'm just kidding. All right, over 92%, close, share results. I'm not gonna wait for you. Okay, so the majority of you, over 50%, said Prevnar 13. That is the most correct answer. Hepatitis B is a virus. It is not a bacteria. Influenza is a virus. It is not a bacteria. Tetanus is a toxoid, doesn't cause bacterial meningitis. So that's how when you answer a question, whether it's boards or your class exams, those kind of things, try to go through and answer to yourself, why are the other answers wrong that I'm not choosing? Okay, or if there are two right answers, why might be one better than the other? So we have Pneumovax 23, we have Prevnar 13. Those 13, we talk about the number of strains or subtypes of strep pneumococcus that is known to cause bacterial meningitis. Okay, we got one more, and then we will kind of move on from this section here, and then I'll go back to the slides. So if we are concerned about meningitis, that's what the majority of you said is the problem. Some of you picked up on maybe it's sepsis. So should we give her steroids now? Do we give them before the antibiotics? Do we give them only once certain things are done? Or now the drools really start? The Napoleon Dynamite went from the lip hanging down to now drool. So just put on a bib and, you know, it'll catch it. I have one myself. All right, we are at 50 seconds. 80% of you, come on, guys. You other 15% slackers, stop watching TV, stop social networking, whatever it's called. All right, closing the poll. Share the results. All right, so this answer, 44% of you say yes before antibiotics, because I suspect that those of you that put that the primary problem that you think is going on is meningitis, okay? But obviously the steroid use would be different if I truly believe that the underlying problem to this patient was sepsis, okay? And so these questions were asked on purpose because this goes back to why we do what we do. So this patient does have meningitis, okay? If you look at, again, the pattern of association, the nuchal rigidity, headache, feels uncomfortable, neck stiffness, elevated white blood cell count. She's a Hispanic female. That doesn't necessarily mean that the Hispanics don't get immunized, but let's say she's a refugee or somebody who's evacuated from across the border and don't have access to resources, which was actually what happened. I practice in Texas. The border's not that far away. People cross the border all the time and come in without vaccinations, immunization. So it's common for me to still see or encounter that. But in certain other places in the United States, it may not be necessary or to do that, okay? Now, let's talk a little bit about what steroids in their use in meningitis. Well, the original study that kind of got it on the scene, if you will, that brought the attention to the medical community that maybe steroids were beneficial was a steroid published in, or the study published in New England Journal of Medicine in 1991. It was a prospective single center. So that was highlighted on purpose from a understanding clinical research, pros and cons to study design, the risk of bias being introduced, and those kind of things. So you have a prospective, single-centered, double-blind, placebo-controlled, randomized controlled trial in Costa Rica. So anytime you read a study, the question is, does this study apply to the patients that I'm either seeing or that I traditionally take care of? And it may or may not be. Do patients who live in Costa Rica reflect the rest of the world? They may or may not, depending on the topic or the subject area, okay? So these things become important as you reflect the ability for you to externally generalize the information from this particular study, okay? But the reason they brought it up is the thinking that, well, with infection of these the cerebral hemisphere, that there's inflammation, there's swelling of the brain, and if we can reduce the inflammation and the swelling, maybe that will contribute to the reduced comorbidities or complications associated with meningitis. And so what they did is they looked at infants and children, infants being as low as 6 weeks of age, which you know is fairly close to being born, and means that they're at higher risk of neonatal related infections that can cause not only pneumonia, sepsis, but meningitis. And that's why in that first, certainly month of life, but even in the second month of life, if they come into the emergency department or a clinic and they have a fever, they pretty much automatically get a full-blown workup of not only blood cultures and labs and admission and empiric antibiotics, but they also get a lumbar puncture to rule out that meningitis isn't part of the problem, because it's devastating to miss that diagnosis and can result in irreversible brain damage, okay? So that's this patient population that we're dealing with. They were diagnosed with bacterial meningitis. So this is not viral, it's not fungal, it's not aseptic, okay? And we see that they received dexamethasone prior to cefotaxime. So see, the context of how it was even used reflects on how you should then use it in real world practice. And that's why I asked the question, Should it be before or should it be after? Does it matter? It's all this debate, okay? But I'm just giving you the facts of the study. So they were looking at surrogate endpoints being sometimes not always patient specific, but are interest to us. So they looked at cerebral perfusion pressures, they looked at inflammatory markers, and they basically show that steroids reduce inflammatory markers. Duh. I mean, you could probably have predicted that, but they proved that point, okay? And that these patients had lower, basically CSF pressures when you measured it on a lumbar puncture. They also showed that they had less neurologic complications. Okay, so that gained attention because obviously having permanent brain damage can't fix that. So if we can prevent that, especially early on in life, that's a good thing. Well, that stimulated, well, do we see the same results in adults? And that was a New England Journal of Medicine study in 2002. Okay, and in that case, this was a multi-centered. So they took the limitation of that single center studied in Costa Rica in just pediatrics and just said, well, we're going to make it more robust, which actually reduces the bias, increases the internal validity, which allows us to externally use it when we're using it across multiple centers. Now, it was multiple centers in the Netherlands. So does that apply to the United States? Different parts of the world. And that's something that you have to ask yourself, okay? It may be very different from one person to another. They used dexamethasone 10 milligrams IV every 6 hours, so 4 times a day, okay? And the first dose was given prior to, usually around 20 minutes before, the first dose of antibiotics, or they could be administered with. And that's sort of where the recommendation came from of if you're going to use it and you have high clinical suspicion for bacterial meningitis and you believe this data, then that's when you should use dexamethasone. Now you see that we use dexamethasone again. Okay, we're going to come back to why we chose dexamethasone. Okay, because it's important. It wasn't just flip a coin or put a bunch of steroid names in a hat and pick the one that you pick out, and that's the one we're going to use. There's actually pharmacologic rationale for why we chose, or they chose, in both studies, who are not the same researchers, dexamethasone in the context of bacterial meningitis. And so what they showed is that there was a reduction in unfavorable neurologic outcomes, reduction in mortality, no increased risk of GI bleed, because steroids are known to cause gastric irritation and can theoretically increase the risk of GI bleed. So they looked at that as one of their endpoints. Now, let's interpret and stop for a moment, because you should be able to learn how to read and interpret literature, because many exams do ask you these questions, but you're a lifelong learner. The expectation is that you're reading literature and then you're keeping yourself up to date, and then you know what to do with it. So you've got to be able to read numbers, look at data, and do some basic fundamental interpretation. So if you look at this 95 or this relative risk, let's say for a reduction in mortality. So what is the relative risk reduction then in that case? Well, that means it's 1 would be no difference, because remember, relative risk is just the incidence of the exposed group to an intervention divided by the incidence of the outcome in the unexposed or placebo group. Right? So it's just a math problem. It's a numerator divided by a denominator. And if those two numbers are the same, then clearly the relative risk could be 1, which means that there's no difference. So when you read this, the relative risk reduction, if the relative risk is less than 1, then you know that some risk has been removed from the patient by taking a steroid. So if you go 1 minus 0.48, then that's 52% of the risk of dying is removed by the use of dexamethasone 10 to 20 minutes before the first dose of antibiotics, and then every 6 hours thereafter. Okay, that's what it means. That's how you interpret it. Is that relevant? Well, if you have bacterial meningitis and you just looked at that result by itself in isolation, you go, I think that probably is worth taking the chance. Because you can say, well, what's the ramification if I give somebody a steroid and it doesn't do that? Is it bad? Does it hurt me? Does something bad, do it might worse outcomes? Well, no. So it might help you, but it might not help you. I mean, you don't know, right? But this data would suggest that it's going to potentially has a risk of ability to save your life and remove the risk of death by 52%. That's relevant. Now, if you look at it, are any of these statistically significant? I didn't say clinically significant. I think we recognize that it sounds clinically relevant, but is it statistically significant? You should be able to look at a 95% confidence interval and read it, knowing that 1.00 is no difference. So if the 95% confidence interval includes 1.00 in it, then theoretically, the true population result could be 1.00, which is no difference. So if you see a 95% confidence interval that does not include 1.00 for a relative risk or a hazards ratio or a risk ratio or odds ratio, they're all calculated the same for the most part, very similar, then it cannot be statistically significant if it includes 1.00. So both of these numbers do not include 1.00. So as a result, they both have p-values less than 0.05. Now, do I know what the p-value actually is? No. Okay, but remember, all a p-value is telling you is whether or not the results of a study are due to chance or random error. So the smaller the p-value, the more believable the result of that study is. Okay, that's all a p-value tells you. It does not tell you anything about clinical relevance. Okay, and that's left up to you to decide. Well, Cochrane Review was done, looked at 25 trials of varying levels of quality, because remember, junk in is junk out in a meta-analysis. And what they showed is a non-significant reduction in mortality. Why? Because if you look at the relative risk and the 95% confidence interval, it crosses through and includes 1.00. So that's why I'd say non-significant. Okay. Lower rates of severe hearing loss. That sounds kind of relevant, especially in kids, right? You know, learning, growth and development, maturation. It's going to affect, you know, knowledge acquisition and all that stuff. Loss of lower rates of neurologic complications, right on the edge. Subgroup analysis showed that it was only really in strep pneumo patients. So if you think about the two vaccines and immunizations that we use in clinical practice, the Prevnar 13, Pneumovax 23, that's in outpatient ambulatory care. Why are we pushing those? Why are we administering those? So that we don't see this scenario. And guess what? Has it worked? Absolutely. The primary care preventative approach has significantly reduced the incidence of bacterial meningitis to where I rarely see it. I still do lumbar punctures in the emergency department for patients with suspected meningitis, but it's almost always either viral or aseptic meningitis at this point. Unless I get someone like this, who's an evacuee or a refugee from another place with lower access to resources and may not have been immunized, or what we're seeing in this country are groups of people who are against vaccines, and those parents are choosing not to vaccinate their kids. And so the herd then doesn't get vaccinated, and then we see these things popping back up again. But that's why we still have to do it. So I've only had a couple cases of bacterial meningitis so far in my own practice because of these vaccines that basically have significantly reduced it, okay? All right, so when we kind of pull it all together, you know, in this case of meningitis, I mean, we know the concept of thinking about steroids, if you're gonna use it, right, it may, it's not a definitive statement, right, it may help reduce neurologic complications, especially if you have underlying strep pneumo, okay? But remember, we have vaccines against H influenza, Neisseria meningitis, strep pneumo. Those are the three main bacterial organisms associated with bacterial meningitis. And we traditionally immunize kids as they go through their, you know, immunization schedules against those things, and that's why we don't see them as much. And steroids, even if they don't help, if I give you some and I get the empiric evidence back from the cultures and sensitivity, or gram stain, and it shows that you don't have bacterial meningitis, well, then I just stop the steroids, right? But empiric means I don't know. If I could do a lumbar puncture and go, oh, I can see the bacteria floating around in your CSF, then I would have more of a diagnosis, but I don't. I have to wait for the gram stain to come back or the culture to come back to do that. So empiric means we are doing it in advance of, under the impression or knowledge that we think the patient has, because failing to start appropriate therapy early on, we know in sepsis, meningitis, a lot of conditions, we lose the efficacy and the benefit, right? Think of it about even outpatient management of influenza. For most patients, the earlier you start, Tamiflu or also Tamivir is in that first 48 hours. That doesn't mean patients won't benefit beyond 48 hours. They actually still do, especially if they have other high risk situations or comorbidities. You still actually use it beyond 48 hours. But the maximum and early benefit is the earlier that you use it. Same thing with like a drug like Crofab, which is the antivenom for a pit viper snake bite. The efficacy is maximized and best in that first 6 hours from the time of the bite and envenomation. So, there are time-sensitive reasons that we do things, and if we have to stop it for whatever other reason, or we get new information that comes back, well, that's fine. That's why it's called prophylactic or empiric therapy. All right. Now, there was a question from Elizabeth that said, but if we were to use Vanco, then we wouldn't want to use steroids yet. So first of all, vancomycin is part of the empiric regimen for meningitis. And theoretically, the blood-brain barrier was put into place to keep things out of the brain. Okay. And theoretically, if you reduce the inflammation of the blood-brain barrier, you will decrease the penetration, okay, of a particular antibiotic in the central nervous system. However, if you look at bacterial meningitis, it is almost never, ever due to vancomycin, okay? Due to a strep or staph species other than strep pneumo, okay? So staph is almost never there. And the exception to the rule is if you have a intracerebral device like a shunt, okay, or you have a traumatic injury where the skull fracture, and now you have exposed brain tissue because we have staph on our skin and on our scalp that can get introduced into the brain. But rarely ever is vancomycin of any benefit or value in meningitis. We do it empirically, okay, to cover the just in case, but rarely is it ever beneficial. The first drug that we always use, whether it's ceftriaxone, cefotaxime, that's the drug that matters beyond vancomycin. So just to put it into perspective. So sometimes we are taught things and we sort of hear things, but we also need to put it in the proper context of really what's the value. Now, if I have a neurosurgery patient with an open skull, then vancomycin is very much differently viewed in that situation, okay? Hopefully I answered that question. All right. Now, what if this patient, and it was not 27 or whatever, but was now 57 years old? Now what do we do? Okay, so let's consider our next poll. She's 57 years old. Do we do anything different? Yes. She needs additional antibiotics. Yes. She would need a dose of Prevnar 23. No. We treat 27 and 57-year-olds the same. We don't discriminate. Busta, you're killing me. Remember, just keep in mind in medicine, there are very rarely ever any absolutes. Almost never absolutes that apply to every scenario, every situation across the board. People that teach in that level of generalization without proper context don't understand the literature and the application. Practice of medicine is very patient specific and does vary from one patient to another in scenarios, and not everything fits perfectly in the guidelines. In fact, if you are a purist in evidence-based medicine, you would not even use guidelines because most of your patients don't fit the studies of the inclusion and exclusion criteria included that make up some of the guideline recommendations. So you can just throw them out the window. So there's a balance in between, and we have to be cognizant of that bias and potential. Those don't make good questions on exams though, for especially boards. All right, let's look at our results. So kind of got an interesting distribution here. Basically, what it says is as a group, largely, you're guessing. Okay. Now, those of you that put 37%, yes, she needs additional antibiotics, that is the most correct answer. Okay. And you may be 37%. Well, I'm not confused. I know the patient needs an additional antibiotic, but some of you in that 37%, I suspect, or potentially guessed. Certainly the other two are flat out wrong. Okay. And so let's look at this again a little bit more in depth here. All right. So when we think about meningitis and core empiric regimens, you have to break it down by age group based on the likelihood of the etiology. Okay, so less than 1 month old. You look over here, you see treatments like ampicillin plus cefotaxime, ampicillin plus gentamicin, but it says note no what? No ceftriaxone. And why no ceftriaxone? Because in that first year of life, that first month of life, sorry, they're at higher risk of hyperlipidemia due to the jaundice and stuff like that from just the birthing process and transition from out of utero. And so their risk of kernicterus is higher. And theoretically, ceftriaxone can cause biliary sludging, which essentially would clog up the bile and it would back up, and therefore your bilirubin levels would go high, and it could penetrate into the brain much easier. And then what happens is kernicterus is a permanent brain damage, and so that's not a good scenario. So we avoid basically ceftriaxone in that first year of life, but we do have ampicillin being included in that regimen. Now, you don't see vancomycin there again, because if you look at the common bacteria, staph is really not around. Okay. Now, once you go beyond 1 month to 2 years, then you see vancomycin plus ceftriaxone or cefotaxime. And I bring out the or because you need to know both. You may always see ceftriaxone. That's what you're always told, and that's what you're always taught. But the reality is, if you look at some of these studies, they use cefotaxime in some cases. Now, they're relatively the same drug for the most part, but the point is that both options are appropriate. And that same thing from 2 years to 50 years. But when you get over 50 years old, like I asked, what if the patient was 57? Now it's vancomycin plus ceftriaxone plus ampicillin. And ampicillin is now covering that listeria that we see in 1 month olds. It shows back up in a higher incidence when you get over age 50. And we don't have a vaccine against listeria. Okay. So that's why we include ampicillin in those specific patient populations. But even if you look at vancomycin, going back to Elizabeth's question about steroids and reducing penetration to the brain and all this stuff because we give a steroid. But if you look at the most common bacteria cited by guidelines and stuff, they don't list staph. So why are we giving vanc then? Okay. But, again, it's because vancomycin has a little bit of strep coverage, and it can be additive to other drugs, but it's really not the thing that you're benefiting from mostly. Let's just cut to the point. It's not. All right. Now, we're going to come back to the whole thing about sepsis here in a little bit, because if you thought sepsis was the underlying problem, then vancomycin definitely becomes more relevant to consider upfront and early initiation. But in that case, if it was sepsis, we would not be using steroids early or upfront. It'd be after the fact, and we still needed some help. Okay. Now, remember, the beginning of the case, she reported penicillin allergy. She didn't say what penicillin allergy, but she has a penicillin allergy. Okay. So let's do our next question. So we have 10 polls, and we're halfway through our polls here. So what is the cross reactivity between penicillin and cephalosporin? So if someone was allergic to penicillin, can I give this girl ceftriaxone or cefotaxime? And if yes or no, or what's that risk of cross reactivity, that if you're allergic to one, you're going to be allergic to the other? This is what we teach historically versus what the evidence, especially newer evidence, actually conveys. All right. 80% of you have voted. We're at 40 seconds. Come on. All right, we're almost at a minute. 92% of you. Come on, you other 8%. What are you doing? You having a seizure? All right. Share results. Again, we got a little bit of guessing or not sure. So traditional historical teaching, and the reason I ask this question is because there's actually still schools, programs, faculty who still teach the old information. And it's very obvious that that's still happening in a third of you that believe that it's 5 to 10%. That is not the case. That is the old historical teaching, because back in the day, when we only had really first generation cephalosporins, they were more likely to have a cross-reactivity versus second, third, and fourth generation, which as you go down the generations, the incidence gets lower. And it's also reflective of poor studies, whereas the new studies range from somewhere around 3%. So the 3 to 5% is what probably most people say is the true real world. But even some evidence says less than 1%. And that's why some of you chose less than 1%, okay, or around 1%. So depending on what you read, but remember, typically those studies that look at that and find the 1%, they don't reflect the general population. But if you were to study remember, we only study a sample of the population. And that's why we get a 95% confidence interval with our data, so that we can look back and say, well, what is the true population value? And remember, as the sample size goes up, your 95% confidence interval shrinks because it becomes more like the general population. As more people are included in the population, it looks more like the population or true value. So the true value is probably around 3%. You know, some people have said even 1 to 3%. Now, what would a board exam say? I don't think they're going to go here, to be honest with you, because there are some differences. You can see that even people are still taught old information, you know, and those individuals contribute to questions on exams and stuff like that. All right. So when we look at cross-reactivity, a lot of this goes back to looking at, you know, these are beta-lactams, beta-lactam being the beta-lactam ring. So if you look over, oops, sorry. If you look over in the square in the middle, right here on penicillin, that is a beta-lactam ring. These are both, you know, cephalosporins, penicillins are beta-lactams because structurally they look the same. Where they differ are these positions here in the molecular structure. And you're like, I don't care about structural characteristics of a stupid drug. I mean, I'm not going to remember this. I agree. I don't remember it either. I don't memorize the stinking structures of every stinking drug. No one, that's unreasonable. Okay. And you can look that crap up and study medicinal chemistry when it's relevant. But where it becomes clinically relevant is that the understanding, or at least having the perspective, that functional groups and their presence create similarities in patterns. Remember, our immune system reads things, antigens that are coming into our body, not just pollen and grass, but drugs. And when our immune system sees something, it may go, gosh, I don't like the way that thing looks, and it ain't supposed to be here, so I'm going to get rid of it. And so it induces this immune reaction against that substance. And some people have a exaggerated immune response, and some people don't have one at all, right? Like I have no allergies to penicillin at all. I can take anything I want with no problems, right? But somebody else may get penicillin or cephalosporin and have an anaphylactic reaction within 30 minutes to an hour of receiving it. Why? No different than why to peanuts. Okay, well, that's genetically influenced at some level. Our immune system, for some reason, overly reacts in an exaggerated way to something that we're seeing. Okay, and so when you understand patterns and you look at similarities, when you look at first generation cephalosporins to compare to penicillin, they look similar. They look more alike. And so that cross-reactivity is a little higher. But as you go down the generation, okay, to like third generation cephalosporins like ceftriaxone or cefepime, which is a fourth generation cephalosporin. And then you get ceftaroline and ceftolozane and all this stuff. They look less and less alike because of these functional groups around the molecule in the beta-lactamine. They're still beta-lactams. So that translates into the so what, who cares, the why as it relates to chemical structures and why it happens. Well, what about carbapenems and monobactams? They're beta-lactams, antibiotics. You know, we have ertapenem, meropenem, doripenem. What can we give those? Well, depending on what study and type of literature you look at, you can see varying rates and incidence of cross-reactivity. But the newer and newer information that keeps coming out, it's showing that it's getting smaller and smaller too, almost like cephalosporins, to where some institutions even allow you and encourage the use of the drugs in someone who's penicillin allergic. Now, you got to be still careful. That doesn't mean it's zero or irrelevant. It just means that you weigh the risk and benefit, especially if you have no other options based on the situation that you're treating. Monobactams like ace-trionam doesn't really have any with penicillin. It's considered almost neutral, except ceftazidime. There have been case reports of cross-reactivity with ceftazidime. Now, case reports don't prove causality, do they? No, they do not. That's traditionally randomized controlled trials. So even case studies, you got to put in the proper context. So if our patient had anaphylaxis to penicillin, and we were truly concerned about bacterial meningitis like we thought she did, well, what can we then give her? Well, carbapenems, probably not. I don't know that I want to create anaphylaxis in the midst of meningitis, especially if I have something else that I can use. Moxifloxacin, you know, she was 27, so she's not pregnant, so it'd be fine to use that. Okay, chloramphenicol, I mean, holy cow, that's like pouring gasoline into somebody, right? That stuff's terrible. I haven't even seen it in practice, to be honest with you. But what if she was 57 and allergic to penicillin, which is what ampicillin is, right? It's a penicillin agent, it's a beta-lactam. Well, what are you going to do for the listeria? This is where you need to know drug of choice versus the alternative. So if your patient is pen allergic, then what are you going to give to replace the ampicillin? Okay, and that's where Bactrim comes into place. Trimethoprim, sulfamethoxazole is your answer. Okay, so you need to know those things. Now, going back to our question of why did those two studies, the one in Costa Rica, New England Journal of Medicine, and the adult meningitis one, that study was done in Netherlands that was published in 2002, New England Journal of Medicine, they both chose dexamethasone, right? Well, we have a lot of steroids. We have budesonide or betamethasone. We have or budesonide. We have prednisone. We have prednisolone. We have hydrocortisone, methylprednisolone. Well, which darn one do we choose, and why did they, the researchers, choose dexamethasone? And that's where we start thinking about the relevance of difference between them. So if you look at our steroids, they're broken down traditionally in those that are long-acting steroids versus short-acting steroids. So long-acting steroids are dexamethasone, budesonide, betamethasone. Short-acting, common ones like prednisone, prednisolone, and then methylprednisolone, okay? How do they differ? Well, they differ in these four columns. So obviously with half-life, long-acting, short-acting, that's going to affect the plasma half-life as well as the biologic or pharmacodynamic effect happening. So potency, they're different. Now, where does potency come into play? Like, so what? Who cares? Why do I need to know that? If you look at dosage in the milligrams that you administer from one steroid to another, they're not the same. And that's where the potency comes in. Potency just is talking about how much drug do I have to give to exert the pharmacologic effect. Going back to pharmacodynamics and the core knowledge, right? Remember, because we're taking core knowledge, we're applying it through a case. Pharmacodynamics is talking about the effect of the drug once it gets to the site of action. And the ED50, or the effective dose at which 50% of the desired effect occurs, is the reflection of the potency. So the more potent a drug is, means I just have to give less to exert the pharmacologic effect. It doesn't make it better. It just means how much do I give the patient to exert the pharmacologic effect or the biologic effect in this case. Okay, because all steroids bind to steroid receptors and affect gene transcription translation. Then we look at our sodium water retaining. That is called mineralocorticoid activity. So steroids have the ability to cause sodium water. Remember, sodium is going to attract water. Water follows it. The plasma volume goes up. I can start creating edema. Well, if I have cerebral edema and meningitis because of inflammation, I have swelling in my brain and my head is hurting, do you think I want a steroid that's going to facilitate further swelling? No, no. So that's why dexamethasone in part was chosen for this situation. We're talking about a central nervous system problem in a closed skull. There's only one opening. It's called the foramen magnum, where your spinal cord is attached to the medulla oblongata and your brainstem forms. Okay, that's it. So if you put pressure in your brain, it's got nowhere else to go but down through that hole. Okay, so dexamethasone has almost no mineralocorticoid activity, so it therefore should not facilitate more cerebral edema in the context of meningitis. Okay, now if we're talking about sepsis, okay, or patients with adrenal insufficiency, where we do use drugs like hydrocortisone in the inpatient and outpatient environment, like we use hydrocortisone in the outpatient environment to manage adrenal insufficiency. Why? Because it has mineralocorticoid activity. We want sodium to be retained. We want the sodium to cause the water to be reabsorbed, because they typically, adrenal insufficient patients have orthostasis, hyponatremia, hyperkalemia. So that's what we're trying to treat. We don't use traditionally dexamethasone to treat adrenal insufficiency. In the context of sepsis, we're using steroids after IV fluids, after empiric antibiotics, and they're still hypotensive or their MAPs are not greater than 65. We add on hydrocortisone. We don't add on dexamethasone or budesonide. Think about croup, outpatient management of viral croup. Parainfluenza virus causes subglottic swelling of the airway right here. Okay, to get that bark sea-like cough, what do we treat it with? Dexamethasone budesonide. We don't want to facilitate more edema. We want a steroid that will reduce the inflammation and the swelling without causing sodium water retention. So guys, it's important to understand that we do use these drugs and certain agents in one condition over another for reasons that go back to the pharmacokinetics, go back to the pharmacodynamics of the drug. Okay, and biologic half-life is talking about what does the drug do once it binds to the receptors in the cells. The drug may actually bind to a receptor, turn on a series of reactions, but then go away. Okay, the drug leaves, but the biologic effect is still lingering. And that's why if someone's on chronic steroids for 2 weeks or more, you have to taper them off because their body is now dependent on that influence of the steroid. And all of a sudden, if you just remove it, you lose that effect. Okay, so we've covered a lot of things in case 1. Things like disease states, pharmacology, pharmacokinetics and dynamics, drugs of choice, alternative drugs of choice, and why and when do we use it. We even incorporated evidence in its proper context. So what I'm trying to teach you is, as you study and you go through your training, don't just memorize things. Ask yourself, why does this matter? How can I understand this so that I can retain it and apply it to my patients in the real world setting? Because you can memorize your way through school, but you can't keep memorizing your way through clinical practice. It ain't gonna work. Your patients don't present as a multiple choice question. They just don't, okay? And so you have to understand why you're doing what you're doing, otherwise you will commonly make mistakes. All right, so now I've incorporated a little what we call rapid fire review of core content, okay? This is just meant to kind of shift it up a little bit. I know we predominantly do cases, but it's important to stop and think about other things. And we're kind of been talking about infectious disease. I mentioned croup, I mentioned meningitis, we talked about sepsis, and we talked about vaccine preventable illnesses. And so it's kind of just nice to stop and do that for a moment. And you need to learn how to think forward, and you also need to think backward when you're studying. So if you look at a drug class or something and you're learning that medicine, what is it used for backwards? And vice versa, if I have a diagnosis or a problem, what bugs does cause it? And then what should I be using for it? Now you have some of this stuff in your lectures, right? But the point is that you consider these things. So strep epidermidis, staph aureus, malignant cases in diabetics. We use eardrops. That's otitis externa, basically swimmer's ear. Okay, so the outside of the ear canal is infected, not a middle ear infection, which is otitis media, where we see some of the vaccine preventable illnesses being the primary cause. Same bugs that cause meningitis. So many of the organisms that cause problems up here also cause here. Sinusitis, strep, otitis media, a lot of them are the same bugs, okay? And amoxicillin is still the drug of choice in that situation, okay? All right, let's take a poll here. So thinking about otitis externa and otitis media, if kids have eardrops, do we give those patients steroids in the eardrop? So otic solutions that you put in the ear. If they have ear tubes, that means there's a communication from the ear canal straight across the tympanic membrane, straight into the incus malleus and stapes, little bones, and blah, blah, blah. Middle ear. Yes or no? So Sophia, I'm going to come back to SOFA score in a little bit, okay? So it's a good question. All right, I'm running a little bit behind on time, so we're going to answer these quizzes or polls a little faster, because we still need to take a little stretch here. Do we give kids with otitis media and ear tube steroids? The answer is yes, we actually do. Okay, and I know that sounds counterintuitive because typically we don't want to apply steroids to tissues, and the incus malleus and stapes are little bones, theoretically causing osteoporosis of the bones. But in this case, we actually do use it in situations. So Ciprodex and stuff like that is indicated and even used in tympanostomy tubes. Okay. Strep pharyngitis is group A beta hemolytic strep or strep pyogenes, still treated by penicillin or amoxicillin. Bacterial tracheitis is traditionally it's like almost like croup, but it's bacterial in origin, and that's where third generation cephalosporins plus a steroid to reduce the swelling. But if it's not a sick kid that's really bad and they just have a bark-like cough, and that's where croup, which is caused by human parainfluenza virus, we give dexamethasone budesonide. Epiglottitis, this is from H influenza. We don't see this much anymore because of the Hib vaccine that we administer as part of the vaccine schedule. But this is traditionally considered a medical emergency. All right, mental break. Don't drink and prime, or this might show up one day. Okay, guys, why don't we take a stretch for 5 minutes, and then the second case actually dovetails off of concepts that we learned from the first case, because I want to bring back in sepsis, so we should be able to wrap it up pretty quickly. So why don't we stretch for 5 minutes, and then we'll start right back up, okay? And then we'll finish, and then I'll stay on and answer questions that people may have and finish things up that occur at that point. All right, so stretch. I don't want anybody complaining that they get DVTs or decubitus ulcers from participating in these case-based integrated reviews. I'm going to stay here. If anybody has a question and you're just wanting to sit and chat, we only have about kind of 30 minutes left here, but we're going to move through the second case. I don't see any questions, so Um, all right, let's see how. Tony, I'm assuming you're talking about COVID. Yeah. Yeah. So I practice in Texas and in the emergency department. I don't practice as much as I used to, but I do keep myself still engaged in patient care and stuff. And so it was very busy for a while, and a problem. We finally got a little bit of control, but now that all the schools are back in, we're starting to see cases ramp back up. We had a couple local universities like Texas A&M and some other schools have some problems where a lot of people, basically partying and stuff, and so our cases popped back up and started rising across the different parts of Texas. What's bothering me is that we're already seeing flu, and it's this early in the year. And what we've not encountered as a nation is what does COVID-19 look like in the context of also a flu season, and what are co-infected patients going to do? We just don't know. So it's going to be interesting to see what happens. Hopefully people will get vaccinated, but so yeah, it's interesting. And I'm tired of wearing look like Darth Vader when I walk into rooms, it seems like, but that's the only way to keep myself protected, and I haven't gotten it by doing that. When does the penicillin cephalosporin cross-reactivity go both ways? As in, would a patient with a history of cephalosporin allergy? Yes. So I think you just, especially in the first generation agents where you would be using it for soft tissue infections like NAPLEX, probably if you're in the third generation, fourth generation, probably not as much of an issue. Now, if it's anaphylaxis, then that's where you need to pause. I had a patient who had just a rash to penicillin and received, well, now I don't, received a fourth generation cephalosporin, and within 35 minutes into the infusion started having anaphylaxis to a fourth generation. And that's probably because her immune system was primed. So I think you just need to pay attention and just monitor the patient. Don't treat it like it doesn't exist, is where I think most clinicians are either very cavalier and put themselves at risk, or they don't, or they take it too seriously and they don't consider it at all. So there's a balance somewhere. Okay, moving on to case 2. So we have a 68-year-old female with a past medical history of COPD, recurrent UTIs, red flag. Okay, recurrent, that's not normal. Hypertension, tobacco abuse, comes in with a productive cough, shortness of breath, fatigue, COVID. No, I'm just, right, everything is freaking COVID these days, right? Although those symptoms are in line with COVID, unfortunately, although COVID tends to be more dry, but patients can develop secondary bacterial infections, and we're starting to see more productive coughs, or at least I have in the cases that I've dealt with, especially the ones who end up dying. Symptoms started about 2 days ago. Subjective fevers and chills. Allergies, none. Smoker, 1.5 packs per day. Is a social alcohol user. Vaccines, again, she doesn't really know. She just does whatever her doctor says. So what vaccines are we concerned about? Again, going back to even the prior conversation, well, FUI, okay? Sorry about that order. I'm not sure what happened there. So what are vaccines that we are concerned about? In her age group, obviously, Pneumovax, especially the Pneumovax 23. There have been changes in the recommendations about where Prevnar 13 historically was only for children. Then it went to children and adults, and then it came back to, well, only certain adults. The point of this, guys, is don't treat it like absolutes. The reason that there's these variations and stuff going back and forth have to do what is the chance that a patient gets an invasive strep species, right? Is it wrong to give somebody Prevnar 13? No, I mean, good grief, right? It's not the end of the world. Now, can a pediatric patient receive Pneumovax 23 at any age? No. because their immune system is not strong enough yet, especially less than 2 years of age, to to deal with that type of conjugated vaccine. So they, or a polysaccharide vaccine, it's just different. So the formulation influences the ability of the immune system and that patient's ability to generate it. So strep pneumo causes pneumonia. Hib, Haemophilus influenza, is a common cause of pneumonia as well. Okay, so we reduce the incidence of pneumonia by just using those two vaccines, as well as obviously influenza, because you can get secondary bacterial infections from a virus itself. Okay. All right, so I don't know why that's out of order. Phooey on that. All right, so what's our pulse? 103, 102.3, pulse is 110. So this is a problem, right? Febrile, tachycardic, and the blood pressure is low. Typically, when you see a low blood pressure, especially in an older patient, traditionally older patients as we age get arterial sclerosis, and traditionally you see more hypertension. So, you know, I mean, she's got a low blood pressure. This is not good, okay? O2 sats are 92% on room air. She's got a productive cough. You listen to her lungs, you hear crackles in the right lower lobe. So that's concerning for an infiltrate. She's tachycardic on exam. She looks ill appearing. She's sweating. Looks a little dusky. Why dusky? Poor perfusion. Her white blood cell is 13.1 with the left shift showing that she's got more neutrophils, probably a little bit of a bandemia, and her lactate is 3.4. So thinking about this case compared to our first case, right, you see some similarities. The fever, the white blood cells being elevated, okay, the pulse above 90. So that's where that SIRS criteria comes into play, and is this sepsis, okay? You know, what is the underlying problem? I mean, this lady in this case is screaming more of a pattern and association consistent with a pneumonia, community-acquired pneumonia, because she didn't say that she was in the hospital and she's developed these symptoms. She's coming into the clinic. She's coming to you with these problems. So she's coming from the community. Now, if she's coming from a nursing home, then that kind of is concerning, right? Because of the patients that are inside that environment could be a little bit more hospital-acquired looking, or what we used to call as HCAP, right? Healthcare associated pneumonia, where patients come from nursing homes and dialysis centers with higher risk. HCAP and CAP pretty much look the same, and so the term HCAP is kind of dissolved over the past several years and no longer really pushed. But the point of the matter is what did the patient look like and where is their risk factors? So she's kind of leaning again in that SIRS criteria, concern for sepsis, okay? All right, so let's do a quick poll here. Thinking about SIRS, does she have 2 or more of the SIRS criteria, which would then make her or give her the equivalence basically of sepsis? Now, if you're looking for an eagle egg to get special powers, we do need to talk. Hopefully you guys know what the eagle egg powers is from, right? I mean, hopefully all of you have seen the greatest movie ever made. Napoleon Dynamite. For those of you that are kind of still clueless, maybe you're too young to know. You've got to watch Napoleon Dynamite. It's got to be on your bucket list. That and Nacho Libre. Okay, they're just the best. Oh my God. Nacho Libre, question mark. Oh. All right. All right, good. So the majority of you got this correct because I gave you the freaking answer. If you were paying attention. Couple of you are looking for eagle eggs to ingest. Just don't go into your exams, you know, cracking an eagle egg or climbing on top of a maybe we should get some steak. Yeah, the steak in Napoleon Dynamite is the best steak on the face of the earth. All right, enough movies. Okay, remember, we're going to keep it fun. So what is the SIRS criteria? You can be febrile or hypothermia. Okay, so both of our patients, meningitis patient and this patient, meet that criteria. Pulse greater than 90, not 100, 90. Okay, and this is a criteria set that I highly recommend you memorize, especially anybody that is triaging, and you might get these patients even in the clinic. So again, for those of you in the primary care outpatient who goes, I don't care what happens in the hospital, you have to triage a sick patient in your clinic. If they come in and meet criteria, do you need to be calling an ambulance? Do you need to admit them to the hospital? Absolutely, you should consider that. So both of our patients had pulses over 90. So there's two right there. All you need is two or more to sort of trigger a sepsis alert. Then they both had also white blood cells. So technically they had both of these patients have at least three of the SIRS criteria. Okay. So that's where sepsis came in, and why a percentage of you, I think it was 24 or 30% of you in that first case thought, well, maybe this is sepsis. And you were right for thinking that. But the sort of better answer was a little bit more meningitis, just simply because of the pattern of association. This patient is screaming pneumonia, but it's probably now moved systemic, and she tries to have sepsis with the primary source being the lungs, probably. But remember, there was that red flag I mentioned about the recurrent UTI. So maybe she's uroseptic. She had a bacteria and now it's seeding different organs, and really she has a UTI and developed pneumonia from the UTI. Is that possible? Sure, that's called hematogenous spreading. You can develop osteomyelitis from a UTI, okay? It's not very common, but it can. So sepsis is some sort of SIRS plus, you have organ dysfunction or documented infection, and in this case, we're concerned for the pneumonia. Now, where SOFA scores come up are really a kind of a prognostic indicator of mortality. We typically use SOFA scores more in patients in the ICU, so it's not really applicable in the initial triage, because you actually have to have some information to calculate it. If you look up the SOFA score, it is a little bit cumbersome to do. But the SOFA score is really looking at patients who are at high risk for multi-organ failure. Okay, so if your SOFA score is greater than 2, that's concerning. No different if your lactate is greater than 2, that is concerning. And so our patient in the first case had a SOFA score of 3 or more, if I'm not mistaken. So, if you follow all these kind of things, you start lumping these patients into risk. And the reason I brought it up is because the approach to management of sepsis is a little bit different than meningitis, and it influences what you use. So, in going back to the meningitis case, if I really was suspicious of sepsis and meningitis was also my differential, then what cephalosporin should I use? Cefepime or ceftriaxone or cefotaxime? Well, to be honest with you, it doesn't matter. If you really wanted, if you thought both were going on, giving cefepime would cover what you need for sepsis, but would also still treat meningitis. The only difference between ceftriaxone and cefepime is really the coverage of Pseudomonas. And Pseudomonas is going to show up more in the sepsis. It's not going to show up in meningitis. And that's why it's not one of the empiric drugs of choice. So that doesn't matter. Where it would matter is when do you start the steroids. In meningitis, steroids get pushed first or at the same time, whereas in sepsis, steroids are after fluids, after antibiotics have been given. So very big difference in approach, okay? So IV was placed. She was given IV fluid resuscitation at 30 cc's per kilo. Blood cultures, urine cultures were obtained, and empiric antibiotics were started. And of course, she was admitted. Now, IV fluids came on board. She was getting that. Her blood pressure started to come up. Remember, she had a systolic in the 87 range. Now it's 109. So that fluid resuscitation improved her hemodynamics, which is one of the reasons why we want to fill the tank so that MAP stays above 65 in sepsis patients. Okay. Cefepime is started by infusion over 30 minutes, but now after you start it, her vital signs start to decline and her blood pressure starts to go back down again. So what pharmacodynamic effect can explain this situation. She was getting better on IV fluids. I start antibiotics, which should be killing the bacteria in her lungs and in her blood. But now all of a sudden, her blood pressure is going back down. So what pharmacodynamic effect could be contributing to this? To answer this question, you have to think about the mechanism of action, because what is pharmacodynamic, right? Pharmacodynamic is really talking about the biologic effect occurring by that drug. So what's the biologic response? The mechanism of action, essentially. So cefepime is a beta-lactam or a cephalosporin, 4th generation. Beta-lactams, cephalosporins, penicillins, cause cell wall breakdown. Okay, they block peptidoglycan formation that disrupts the cell wall of the bacteria, and it lyses the bacteria open. So it kills it. Doesn't need the immune system, it just kills it by itself. But with gram-negative organisms can release cell membrane components, and LPS is one of those. LPS is part of the structure in the cell membrane of a bacteria, specifically gram-negative, that when it gets released into the circulation, because it's being lysed and killed, can cause vasodilation and increase the vascular permeability of the endovascular lining, and that causes leakage of fluid out, and so their blood pressure can start to drop. So it can be an expected response based on the mechanism of action that you're lysing basically bacteria in the blood, and you're causing a vasodilator response because of the LPS. All right. So if you gave cefepime, you always give the first drug that matters most first. She was also ordered to give vancomycin. So then what is the initial empiric dose? The initial. Okay, so we're dealing with a medical emergency, acute care situation. Early drug therapy with the right medications matters. That's why we've been talking about meningitis versus sepsis and which drugs, what do we really think the problem is? Okay. All right. I'm going to sort of release these a little faster, so you need to answer the question. Okay, when we get to 45 seconds, which is in 5 more seconds, I'm going to shut the poll. All right, so good. The majority of you got this answer correct, 20 to 25 milligrams per kilogram. Now, do you keep them on 20 to 25 milligrams per kilogram? No. That's initial, kind of think of it as a loading dose. We need to get the steady state concentrations. We got a medical emergency. We've got an infection that is moving throughout the body. From a pharmacokinetic and dynamic effect, we want the drug levels to be up there so that they work and get on those bacteria. So the second dose, third dose, and dawn may be different, okay? But that first dose is many times a loading dose. Same thing with cefepime. We're using a higher dose because we want appropriate concentrations to get to the site of action. I don't care what a drug does in a petri dish. I care what it does in a person, okay? Now, what dose? If it's per kilogram, is it the patient's actual body weight, the adjusted body weight, ideal body weight, the lean body weight, Napoleon's body weight, Pedro's body weight? All right. I need some Napoleon pictures. All right, we're almost there at 45 seconds. Come on. Pedro. That's right, Tony. I agree. All right, close, share. So the majority of you got this correct. It is the actual body weight. And the reason for this has to do with the volume of distribution of the drug, which is a parameter reflective of the pharmacokinetics of this drug. So this is why understanding pharmacokinetics and dynamics matters. The volume of distribution reflects where does the drug go? Does it stay in central circulation or does it move out into tissue? The larger the volume of distribution, the more it's going into tissue. That may be good, but it may be bad. What if the infection is in the blood? I need it to stay there, or I need a certain concentration. And so the actual body weight is utilized in vancomycin dosing, which is different from aminoglycosides, which we use the adjusted or ideal body weight in those patients, because it has a much smaller volume of distribution, more likely to stay in the central circulation. And then sometimes we have to give higher doses so that we can push it into the tissue. All right, and that gets into the whole pharmacokinetics and dynamics of aminoglycosides that is not intended to be covered here. I understand you got some level of knowledge of that. All right, so I'm going to hide those and we're going to finish this up. So vancomycin has started, and within 20 minutes, the patient starts to itch. The RN or nurse comes to you and says, you know, what do you want to do? So what intervention can you implement based on the situation? She's getting an infusion of a higher dose of vancomycin. She starts itching, kind of getting the red man syndrome. So what can you do? You just slow the infusion down. Now you can get Benadryl, fine, but really that's not the problem. The problem is the nurse is infusing the vancomycin too fast. So slow it down and it typically goes away. Okay, especially when you're using large doses. So I'll tell the nurse, you know, look, we're using a higher initial empiric dose because this is sepsis. Please give this over at least 4 hours and give it after the cefepime, because I don't really, we're just doing this to check off a box. For the most part, MRSA is probably not the problem. All right. All right. So thinking about our MAPS and our lactate, what is our desired goal, which I've already said, so you should be able to get this answer correct. And what is our desired lactate level? Remember, hers was 3.1 or 4 or something. Should have the case in front of me, but I don't. But what are we trying to shoot for? All right. So it looks like 80% of you are we're at 30 seconds. So I'm going to close the poll. Good. The majority of you got that right. Remember, so our MAP, mean arterial pressure goal for IV fluids, antibiotics, all these things that we're doing is 65. And if you can't maintain 65 after IV fluids and antibiotics, that's when you consider steroids, vasopressors to be added on to the patient's treatment. Okay, vasopressors and steroids, and the steroid being hydrocortisone in that case, not dexamethasone, because we do want plasma volume increases to increase that perfusion pressure, and we want that lactate to be less than 2, not greater than 2. All right. So we just reinforced continued concepts of another disease state, sepsis, which is one of the core disease states that everybody needs to know. It's a core measure in the hospital. We need to be able to recognize it in triage and when patients need to be transferred to a facility or being admitted to the hospital. And when they get discharged from the hospital and their continued management need follow-up, we need to understand how are these patients managed and why does this matter? Okay. And so hopefully you found that to be useful. Now we're going to finish up with our last rapid review, looking at some other material from a different perspective. Okay. So when you're studying material and you're thinking about things, a lot of this stuff is memorization, but go to the next step of how do I apply it? When would it be relevant? All right. So what is this drug? I have a drug with a reference range of 4 to 12. Okay. So if you have to monitor drug levels, which there's not many drugs that we have to do that, you need to know those drugs that commonly are associated with this. A lot of exams like to ask these questions because they're not the norm, but they still are used a lot in clinical practice. Well, that's carbamazepine. Carbamazepine is used for a lot of things. We need to be thinking in your head, what are some stuff that should be popping off in your brain? Well, you can use carbamazepine for seizures. We can use it for bipolar disorder. It's also the drug of choice for trigeminal neuralgia. Unfortunately, it's an enzyme inducer and can cause drug-drug interactions. Okay, so this is rapid fire content. All right, has a drug reference range of 0.6 to 1. That's pretty narrow. That's your lithium. Lithium is one of the most narrow therapeutic index drugs. high risk of toxicity, both in acute overdose or chronic use. Got to be very careful with it. Again, it's primarily useful for bipolar disorder, does require renal dose adjustments, very careful with it. It can cause hypothyroidism because it competes with iodine. It can also cause hypercalcemia because it affects the interaction of parathyroid hormone on the parathyroid gland, feedback loops and stuff like calcium, feedback interaction on the calcium receptors on the parathyroid gland, which then influences parathyroid hormone release. But that's just something common you need to know. All right, drug reference range 50 to 125. Some people would say 50 to 100, depending on what resource you are. That's valproic acid. Valproic acid is also an anticonvulsant used for seizures, but it's also a bipolar or mood stabilizer for bipolar treatment. If you co-administer it with lamotrigine, there is a drug-drug interaction that can cause Stevens-Johnson syndrome. So very important. Make sure you kind of recognize some of those key points. It has a drug reference range of 10 to 20. Well, that can be a number of drugs. Vancomycin, theophylline, phenytoin. Do we use theophylline anymore? Absolutely. It is recommended by guidelines. It's not first line, but it is still used on occasion. You just have to monitor the levels because it can cause toxicity, particularly tachydysrhythmias. It can lower the seizure threshold and cause seizures. All right. Associated with reactions in patients with HLA-B5701. So this is pharmacogenetics and genomics in practice. So before you administer this medication, you have to test for this genetic polymorphism. If it's present in the patient, then they should not get it. And that is abacavir or Xiagen. Abacavir being your NRTI, nucleoside reverse transcriptase inhibitor for the treatment of HIV. So if you look at product package insert by the FDA, you look at the guidelines, they both recommend that you test the patient for HLA-B5701. So, you know, patients or people that tell me that pharmacogenetics and genomics doesn't exist in practice, clearly don't know this drug. All right, 1502. 1502, again, this has been around for a while, but that's your carbamazepine, which we just talked about a minute ago, specifically the Han Chinese. You can develop Stevens-Johnson's, and this is obviously a life-threatening condition. HLA-B 5801, 5801, this is allopurinol, okay, which we use for gout. So it's a xanthine oxidase inhibitor. It is associated with allopurinol hypersensitivity syndrome, especially in the Chinese Asians with CKD. UGT1A1, star 28. This is a phase 2 metabolic pathway of conjugation of drugs. So it's conjugating to make drugs more water soluble. That is your irinotecan, Camptosar, chemotherapeutic drug. Okay, you have to test them, and there is a point of care testing for it. Remember, one of its dose limiting toxicities in the treatment of cancer is diarrhea. Okay. So this was our session 1, kind of getting into 2 different cases. We talked about 2 core diseases that show up in acute care environments, but you can see these show up in the primary care, but the parts that prevent some of these come in the primary care, ambulatory care environment. Why do we learn some of these preventative things? They're vaccine preventable illnesses, and they reduce some of these complications. But when they happen, you need to know how to recognize them, when they need to be admitted, and then when they get admitted and they get discharged back for follow-up, you need to know what to do with them, okay? And making sure that these things come back together and you're following up. I hope that you got to see a perspective of that as you're studying, that you're thinking, not only understanding it, knowing what that thing is or what the mechanism is, but why does it matter? Why would I pick this drug over this drug for this situation? Why do I see this drug being used more in clinical practice than this drug in this situation? Sometimes it's just geographic pattern differences. Sometimes it's just the formulary. What drug is on your preferred drug list? It has nothing to do with any other thing, anything else. Okay. So I tried to show you, for example, like in meningitis, where cefotaxime and ceftriaxone are both equivalent. We see the same thing in cirrhotics, for SBP, ceftriaxone, cefotaxime. They're both recommended. In fact, the evidence is more commonly in cefotaxime than ceftriaxone. So if you're a purist in evidence-based medicine, that's what you should be using in cirrhotics with spontaneous bacterial peritonitis. All right. So I hope that we sort of that I try to stimulate different ways to think about the material, try to throw a little bit of pearls your direction as you kind of digest and you go through your training and you're listening to lectures, you're reading papers, you're reading guidelines, put them in the proper context. Okay. I do want to make a comment about guidelines. They are guides. They are not absolutes. Okay. They do not apply to every scenario, and not all guideline recommendations are based off of good evidence. Some of them have weak evidence, and just because it's recommended in the guidelines doesn't mean it's a strong recommendation. That's why recommendations sometimes have rankings based on the quality. Okay, and then lastly, you need to know that guidelines are influenced and made up by humans who have different opinions about what information is appropriate. Remember, we all have to read papers and interpret the data like we did in some of those examples, and then be able to extrapolate that to the general population or make recommendations when we're going to use it or when we're not going to use it. Not everybody agrees. Not everybody agrees with the use of steroids in meningitis empirically, because we just don't see bacterial meningitis anymore. But at the same time, how much harm is it going to do? And if you miss that one case and you were behind the ball and someone has a bad neurologic outcome, are you legally then potentially liable? You better defend yourself, because you will have to defend yourself in court. And you can't say, oh, I read my professor said this, my faculty or attending said to do that. Well, that isn't going to fly. You are a clinician, independent, making your own recommendations sometimes, and you need to be able to justify that situation. Okay, let's see. Let's see, there was a question from Frank about, please give us some key tips on how you would expect a student to present patients to me. So it depends on the environment, right? So Frank, if we're in the acute care environment, it may need to be a different approach because we have limited time, okay? But typically, the SOAP note format is most commonly what most people teach and train, because we should be thinking that way, right? We get the subjective, the HPI. Now, where I think students make mistakes, or residents and clinicians early on make mistakes, is that they get into every detail. Well, if I ask you a question later on, be able to answer it, but you want to hone in on what you think the problem is, and then give me information that would align to what I think is probably I'm hearing from you, and then give me information of why it's probably not something else that I'm thinking about. So you're trying to read, again, the mind of the person. You may not know how to do that yet, but as time goes on and as you do it, that's the point of presenting, is that you learn how to present information in a concise manner. If I got a patient who's in here with, like our second patient, who's got a productive cough and she's got fatigue and malaise, I don't care that she went on a vacation last week, unless that travel becomes relevant to an exposure. Okay, but if you're just telling me she went on a vacation because she went on a vacation, then that does, because I might stop you right there in your presentation, like, why are you talking to me about vacations in this patient? Oh, well, because it's relevant. She's traveled, and she traveled outside of this border, and she may have been exposed to this. Okay, that makes sense. Thank you for telling me that. Right, so I'll always try to, consolidate information, but be ready to answer other questions when your faculty, the attendings, and your preceptors ask you questions. You need to anticipate those. So it's a good question. All right, are there any other questions that people have, or anything about the cases or studying? Everybody's in a different place, everybody learns differently, but you've got to think about applying core knowledge at a higher level. If not, I'm going to let you guys go. Thanks for everybody's involvement and participation, and look forward to seeing those of you next time as we do some more cases. And like I said, we'll mix it up a little bit, okay? You're welcome, Madeline. Thanks for the feedback. I appreciate you guys. Take care. Bye-bye.